Welcome back to another episode of Claims Denied, a hospitality podcast covering health system transformation, talking to influential leaders across the healthcare ecosystem. Today, I'm super excited to be joined by James Hereford, the CEO of Fairview Health Services. James, thanks so much for being here. Appreciate you taking the time to meet with me.
Oh, Blake, thank you. I appreciate the invitation. Always enjoy the time.
Yeah, of course. And I know we've had a couple of conversations over the course of the last year or so, and looking forward to this next one. One thing I do want to bring up before we get into the meatier stuff is I do understand you are a Montana State graduate, correct?
Thank you for raising that. Yes, yes.
And I was watching. I flipped on the TV.
About the national champions, Montana
That's right.
State Bobcats.
That's right.
Yes, thank you.
A thriller. For the first time since 1984. Yeah,
I thought we were giving that one away, and somehow we snuck a win out of a sure defeat.
Yeah. What a game. So congratulations.
Thank you.
As a UT Austin graduate, my last foray into that space was 2005. So it's been a little while.
Yeah, got to enjoy it when it happens, right?
Of course. Yeah, who knew Montana, just juggernauts of football. Montana State and Montana, I should clarify.
Yeah,
right?
Let's not confuse those two. This is the real school at Bozeman, not whatever that is at the university in Missoula.
Of course.
There's no rivalry there.
No, none to record, for sure. Well, James, with that aside, I would love to get into kind of your backstory. I know, from what I understand, you have a pretty unique backstory when it comes to healthcare and getting involved into healthcare, and then Fairview specifically. So, I'd love for you to kind of take it away and give me your journey up to this point.
Yeah, I usually describe it as a random walk through career space, which also probably tells you something about my education and training. So, my degrees are all in either mathematics or statistics. And in large part, just because those ended up being the classes that were easier and path of least resistance, didn't have labs, et cetera. But graduated to our earlier conversation with a master's degree in mathematics in Montana State. I always like to think of it as the Stanford of the Northern Rockies, but be that as it may. And so it presents the question, well, what do you do with a master's degree in mathematics in Montana? And again, a little bit of the path of least resistance. I ended up coaching high school basketball and teaching mathematics for 7 years in a little town called Lewistown, Montana, which is a little slice of heaven, right? It's got a blue ribbon trout stream that literally runs through downtown. The way they recruited me there was they took me down to a bar on Friday night after a long day of interviews. You walk in and there's a plexiglass floor and you look down and they go, oh yeah, that's Spring Creek. That's the blue ribbon trout stream. So I did that for 7 years. The standard line is you can only teach algebra 2 trig so many years in a row before the thrill is gone. And we're looking at, well, what's next? And I had a desire to go back to grad school, so I went to the University of Washington. They had a very good program in statistics to work on my PhD. We found out we were pregnant with our first child after I passed my first year qualifiers. We found out we were pregnant with our second child after I passed my comps after my third year. And I got very revenue motivated. And, in hindsight, you can see the turn, but at the time you didn't know. I was just trying to find another avenue to make money. So I'm teaching a course, summer quarter, University of Washington. It is absolutely gorgeous. Summertime in Seattle is amazing. But teaching a stats class to a bunch of engineers, summer quarter, less than amazing. Nobody's very excited to be there. So I get in the morning, I'm preparing for my class, and there was a note sent by the department chair that he'd received from the Boeing Commercial Airplane Group that they were starting the 777 build. So, this was several years ago. It's like 1990. They were implementing TQM, and they were looking for somebody with platform skills who could teach TQM, DOE, SPC, etc. And I read that first paragraph. I had no idea what any of that meant. Second paragraph started with, we're paying $50 an hour contractor's wage. And I'm like, I am your guy. So I run down to the graduate library and I, check out some books, Deming and Juran and Feigenbaum and what have you, to figure out what is this thing called total quality and SBC. And, it made sense, right? You take these tools, fairly simple statistical tools, you put them in the hands of the people actually doing the work and have them monitor and improve their own quality. I'm like, well, of course, wouldn't everybody be doing this? Then I started to teach and then got involved in some project work at Boeing and got an education on the difference between a theoretical framework, total quality, and the application of that in a real world environment, Boeing. And Boeing is especially at that time, it's a very classic, it's not even so much a manufacturer as an assembler of planes. And so ended up getting involved in some of the project work around the production. And I was just fascinated by, it was a very top-down culture. It was very much check your brain at the parking lot, at the gate, and then we'll come tell you what to do, right? You work to a bar chart that just specified how much you should work, how often you should work. I mean, it was a very fascinating environment. And I got fascinated by the clash of this fundamental kind of concept, give people the tools to manage their own quality, and the culture that Boeing had created at the time. And this was when Mullally had just taken over the 737 production. And he brought a different kind of approach to this, which was, again, fascinating to watch. And it kind of derailed what I was doing from a graduate program. I started taking classes in business and psychology, and because it was just interesting to me. Frankly, more interesting than a lot of I was working, my dissertation topic were more computationally intensive or computational efficient ways to do Bayesian analysis. Which probably would have been a fairly lucrative set of work had I seen it all the way through. I'm sure my committee chair has done well. But I found the organizational change and just this application really interesting. And it kind of sidetracked me. And I started doing all this other work and got involved in some of the other work at Boeing to help them build out their own quality system. And that presented another opportunity, which was to go to all their suppliers and help them meet the new standards, right? So they had to supply statistical process control charts, et cetera. So I had to go in and got the opportunity to go in and teach them how to do this. And it was a fairly good gig as a consultant. So I'm consulting around the Puget Sound, and one of my clients was Group Health Cooperative. Kind of, again, random. A friend of mine introduced me to a friend of theirs who was the VP of quality at Boeing or at Group Health. And they said, well, we're trying to start total quality. Would you be interested in coming in and helping us? And Blake, I knew nothing about healthcare. I mean, my experience of healthcare was basically athletic trainers, right? So,
hey, sometimes that's the best way to be.
Yeah, I was certainly naive walking into it. But I ended up falling in love with healthcare. I mean, more smart people per square unit space than any other industry. It is amazing, right? I describe to people when they're talking about their jobs, well, look, my frontline employees are MD PhDs. So it's not like, people are walking in off the street and are day laborers. This is very highly educated people. It also, the mission orientation, is galvanizing for a healthcare organization. People are there for a very laudable, motivating purpose. That is almost universal. There's a selection bias to people who go into healthcare and healthcare delivery. And then thirdly, their processes were so screwed up. I couldn't help but contribute despite the lack of knowledge I had about what they were doing. Content sequence and timing of a process were foreign ideas to this integrated financing and care delivery organization. Well, this is great. I'm going to do this for a while. They end up offering me a job. I said, well, I don't really like consulting that much. Sure, I'll do this and I'll get my dissertation done and move on. And ended up working there 20 years and had this immense opportunity to, I started out in helping them implement total quality, but then moved into our director of service, and then had an opportunity to help them build out their web offering. This is like 1998. And so this was very early on. And they were thinking about, well, how does the web impact? A little bit like the conversations we're having with AI right now. So how is it going to impact this industry?
Yeah, interesting.
And that led to me looking at Epic and saying, okay, because we had a homegrown results reporting system and it was a kludge, and nothing worked to get the kind of content we needed to the web. And so we were looking at, well, we need a new foundational system. So I was involved with looking at EHRs at the time. There were only two that were even close to viable, Epic and Cerner. And we couldn't find an instance across the country of Cerner that was completely implemented across both the ambulatory and the inpatient environment. And at the time, Epic was a very different company. I mean, it was small, it was in Madison. Their headquarters was an old schoolhouse. They had one salesperson across the country. I mean, it was a very interesting organization. And so it was a pretty easy decision. And we ended up deciding on that. I made a plea to the chief operating officer at the time that said, look, I think we should do this. This is a no-brainer for an integrated healthcare organization to have integrated information. And I'd like to lead it. Because if you let IT do this, you're going to get an implemented system, but you're not going to get the transformational impact. And John Long was the chief operating officer at the time, wrote me back, said, well, great idea, but you can't do this from your role as a director of customer service. What are you going to do? And I went home that night and I'm watching channel surfing and surfing past the University of Washington TV station, which they had a panel of medical informaticists debating what is medical informatics. I thought, this is great. If the professionals can't agree, I'm going to call what I'm doing medical informatics, and nobody can tell me I'm not doing it because nobody can agree anyway. And so we created a medical informatics function at Group Health that really our first set of work was around implementing an EMR across the system. It was a pretty good sized system, a couple of hospitals and 25 clinics and 14,000 people, and deeply integrating the web, pulling our previous work forward into that. So at one point, after we'd implemented Epic, we were the biggest clinical web user in the world. Now, that's not saying a lot because it was pretty early days, 2003, 4. And we maintained that position until Kaiser came along and implemented, and then they squashed us like a bug because of their sheer scale. But learned a lot about, just the guts of clinical care delivery work. I spent an immense amount of time, on workflow and, how do decisions get made. And it was a great laboratory for me to learn all about this. And, the nice thing about an organization like Group Health that integrated financing and care, I sat with the health plan guy every week at the leadership team meeting, talking about how do we better integrate financing and care and some of the challenges, even in that environment, of doing so. So did that work. There was a CEO change, and Scott Armstrong became the CEO. Scott asked me to take on an executive role. This is 2005. And I had, we called it S2Q. So strategy, strategic services, which included quality, IT, and then strategic planning, which again gave me another view of the organization, and also had HR and people, and so it was all the levers to create change, and that was my mandate from Scott, was drive change. We were an old, established in 1946 socialist wobbly organization. Everybody wearing Birkenstocks, and it was kind of the ethos. And that clearly was not going to be good enough for us to continue to be competitive. And so my mandate, my charge, was to really drive change, and gave me all the levers outside of finance to do that. And it was a great run. And unfortunately, Scott was a year younger than I was. I was on the succession track to be the CEO, but unless Scott went somewhere, I was not ever moving into that role. I got recruited down to California, first at the Palo Alto Medical Foundation, and then got recruited across the street to Stanford because a friend of mine, Amir Rubin, who had been the chief operating officer at UCLA, it's how I got to know him, became the CEO at Stanford. He was looking for a chief operating officer. He calls me up, says, James, would you be interested in this job? And I go, Amir, I can't. I've only been at PAMP for 18 months. I can't leave. And things are going really well. And the thing about Amir, I don't know if you've ever had him on your podcast. He'd be an interesting guest. He's interesting in so many ways. Is he doesn't hear no very well. And he's selling a really good product in Stanford. And I had not had experience in academic medicine. I thought, well, this is great. I mean, this is an opportunity for me. And at Stanford, there's, all the kind of halo that goes around that. And so was the chief operating officer at Stanford for a number of years. Again, really got an in-depth crash course on academic medicine and, what it was like to be in that ecosystem. And it really is. Stanford is a unique ecosystem, just in terms of being in the Silicon Valley and the role that school plays in generating entrepreneurship is fascinating to be around and be a part of. And so had a lot of nice opportunities there.
I've heard of this new entrepreneur. I think her name is Liz Holmes. Have you heard of her? No, I'm just kidding.
I tell you what, we were dangerously close to signing a deal with them.
Is that right?
Dangerously close. Because I always thought of my role as the chief operating officer is to trail behind Amir and make sure we didn't do any deals that would not work well for us. And this is one that he initially really wanted to do. And we spent a lot of time with our chair of pathology around, is there anything there? And his conclusion, the chair's conclusion was, this is all BS. So thank God we avoided
Good job listening.
But,
yeah.
Yeah, exactly.
Dodged a bullet.
But it was a sexy thing at the time, and they were spending a ton of money. So, Amir leaves, goes to UHG. The CEO job's open. I am encouraged to apply. I had a couple other offers, and I turned those down. I said, okay, I'm going to stay at Stanford. Applied, and up until about 2 weeks before, by every indication, I was going to be the CEO there. And then they met with the President Hennessy, who was the president of the university at the time, they being the search committee, described, candidate pool, and I was leading. And President Hennessy said, no, you got to get somebody with prior experience. And so David Entwistle ended up getting the job, which is great. David's a wonderful leader. He's done a great job. But it also was kind of, okay, well, now what? If I want to be a CEO, what do I do? And had a number of different recruiting opportunities, and Fairview came along. It was like the perfect job for what I was looking for. Real CEO, real board, had the entire continuum of care there. Also had a plan at that time that we've subsequently got rid of. But so ended up taking that job and have been here for I'm in my 10th year now in Minneapolis with Fairview. So truly a random walk. Probably only guided by what can I learn? What's the next thing I can learn? And just, this experience with healthcare, which I've continued to adore over, damn near 40 years now.
Yeah, I mean, definitely a little all over the place by your own remarks, but also I would imagine like a lot of those experiences, as you've alluded to, have shaped who you are and your leadership style and those sorts of things as well. So I imagine that gives you a little bit of an edge. I'm curious if, having those disparate past experiences, what is translated into kind of your leadership and in what you kind of perceive as how you lead your organization today?
Yeah, it's a great point. And I mean, there are two aspects of that. One is kind of my own leadership and how it's impacted it. And, one, I think my experiences, because I've seen so many different aspects of healthcare, is how deeply I respect the people who are doing direct care delivery. I mean, it is, and often under difficult circumstances. Part of those circumstances are self-inflicted in that we're not very good at building systems. We've got intelligent, incredibly motivated people. And unfortunately in healthcare, too often we've said, they'll figure it out, right? It's not a good system, but we put good people in it and make it a better system, make a bad system better. But that's not okay. That burns people out. It takes its toll on the human beings. And so, but that respect for kind of the clinical effort. I think the breadth of, the other thing I learned, and it was a hard lesson at the time, was I was accused of being a little bit arrogant. Always thinking I'm the smartest guy in the room and blah, 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 blah. And you get that feedback one year and you kind of, whatever, that's, kind of went off. Get it a second year, you go, maybe there's something there. Get it a third year, you better pay attention. And
fool me
when I got
once.
to the third year, I went and asked people, I said, look, I'm getting this feedback. Can you help me? And what I learned from that was people tend to want to help, right? So if you are genuinely, authentically seeking input into your leadership practice, people tend to be very supportive of that. And the very fact that you're asking is indicative of your commitment to leadership, which changes their view of you. And so that really impacted the way I thought about leadership. I always thought about it as I had to have all the answers. It turns out, and the further you go up the food chain, the less you're ever going to have all the answers, because you're going to have people around you who are going to be responsible, accountable for finding those answers or solving those problems. Your job is much more about how do you support them effectively and challenge them and create a accountability system where they're rewarded and celebrated for their accomplishments, but feel like they're a part of something larger. And so that had the biggest influence just in terms of how I lead. Now, I was also a basketball coach for 7 years with some success. And so I have a high belief in teams, and I've always brought that, with me into my work, and that also has influenced a great deal, kind of how I think about what I'm trying to do and how I'm trying to build a team and what that team's accountable for. I think the other thing I would say is content-wise. I mean, I've been in a old-fashioned staff model, HMO, integrated financing and care. So had my lessons of value basically taught to me by Ed Wagner, who is a fellow of the Institute of Medicine, basically created the chronic disease model. So, the guy who you could argue invented population health was 2 doors down from me, his office was. And I had the opportunity to really learn from people like he and, Mike Stewart and Matt Hanley, who guys who were really pioneers at this. But also, the great unwashed fee-for-service system. When I was working at the Palo Alto Medical Foundation, I mean, that is what it is you're out there competing against the Stanfords and the Kaisers and the Sutters and everybody else. And having to be able to compete in that way is very different than in a staff model HMO. Then you go to an academic, which has a totally different kind of worldview. You still have to be competitive, but especially at Stanford, the competitive landscape looked fundamentally different, right? Mm-hmm. And you think about, you've got UCSF up the road and UCLA, and, but it's a very different way of thinking about what you do and how you do it. And there's just a different sensibility to academics, and it's not always a good one. It's not always, it isn't a great necessarily adapted to some of the challenges that academics face. But it is very unique, and understanding that was helpful. So I've been able to bring all of those into the current role in a way that is, in many ways has been the perfect preparation to be the CEO circa, 2016 through 2026. These are the kinds of challenges we're facing. We've got to compete. We've got to compete in a, really competitive marketplace in Minnesota. I have an academic relationship with the U of M, University of Minnesota. We continue to have all the pieces and parts for a great value system. Unfortunately, we just don't have the health plan partner that really can help us do that to align the economics. But having a knowledge of what real value-based looks like versus the version that's passed off to us by health plans, which has very little to do with value, has a lot to do with their money and them keeping it. I always laugh when people come along and talk about value, and the way they talk about it from a health plan perspective is, we're going to take your medical loss ratio and put that at risk. We're going to take the money you're already getting paid, we're going to put that at risk. But the 15 to 20 cents on the dollar that we're getting, that's not at risk. Well, that's not value. Value is being able to say that premium dollar, where do we spend it in that entire continuum to have the biggest impact in terms of cost, quality, life expectancy, et cetera. So the natural tendency is much more on the prevention, early detection side, so that you can. But that's not what, when health plans talk about value, that is not what they're talking about.
Yeah, it's fascinating. And you bring up a lot of really interesting topics in that entire chain of thought. And I'd love to double click on a few of those. But first, I have to ask, who's harder to motivate? A high school basketball team or healthcare employees?
Well, that's a great question. So, 16 and 17-year-olds are complex beings with the, not fully formed. And especially in Montana, I mean, we get, by their standards, big crowds, right? I get, 1,000 or 2,000 people in a gym because it's the only entertainment
Is that right?
in town. Oh yeah.
Wow.
So you put a 16 or 17-year-old in that environment where everybody's talking about, especially if you're winning, how great they are. And to be able to get them to commit to team and commit to, shared sacrifice is a challenging task. I think the biggest difference is you are working with fully formed human beings, but really, really smart ones. For the most part in a healthcare environment, is how do you get that sense of commonality? And it's also an issue of scale, right? So basketball team, I got 12 kids, 25 at most of the program. I've got, 34,000, 35,000 employees.
Yeah.
So it's a scale issue as well. It's not like I can just put everybody in a room and give a rousing motivational speech and, connect to them individually. And so the mechanisms are very different to get that kind of alignment and shared purpose and buy-in. So both are equally difficult, but in different ways.
You mean to tell me you haven't tried to get all of your employees at once into Montana State Stadium and just bring out a megaphone?
I've been tempted to try to put them into the U.S. Bank Stadium where the Vikings play, but even that's, it's a little hard. We don't shut down and are able to take everybody offline.
Right.
And so it's just pragmatically, it's incredibly hard.
Yeah, sure. All right. Well, teasing aside, I'd love to maybe could you walk me through because as I understand it, this was when I was kind of starting out in healthcare, kind of 2016. But that's when you became CEO at Fairview, and from what I understand, there was some CEO turnover before you. And talk to me about how you felt entering that dynamic. How you established yourself, and maybe like a few high impact things you did right off the bat to kind of spearhead that turnaround, and then kind of walk me through how that transformation kind of played out from there.
Oh, well, I'd say that being young and naive has its advantages. I had no idea what I was stepping into. I was the 5th CEO in 6 years. And so there had been a lot of turnover. Frankly, I didn't even think about that. I didn't even that was not maybe I should be, cognizant of why that was the case. And there was, a perfectly rational kind of chain of events. 2 of those were board chairs who stepped in an interim role, but ended up in an interim role for an extended period of time. One guy, their first guy got caught up in a scandal. The second guy just got fired. So it was, you walk in and you're young and naive and say, okay, well, let's go.
And you're starting from zero, right? Like zero trust, I imagine.
Yeah. It's interesting because what you're really starting from is if you have 5 CEOs in 6 years, the organization's not done anything. It hasn't moved forward in any way. So really you're 6 years behind when you start. And, but the organization doesn't know that. And so the presenting problem is how do you look at this and not challenge the organization in such a way that they reject you? I didn't want to be the last victim of the CEO turnstile. But bring them along and be able to say, okay, yeah, here's where we're at. But this is the next step. This is where we need to be. So really try to lay out we couldn't even do a strategy initially. It was more like, okay, so what are the things that we've got to do to get better? And really started doing that. And I've always been a pretty big proponent of lean and kind of the lean management system, more so than the manufacturing process improvement stuff. I've always argued that, there's nothing new under the sun in process improvement. I mean, everything in lean is basically, any industrial engineer from the 1930s would be able to tell you, yeah, single piece flow. That's why that would, be more efficient under normal circumstances, et cetera. What was unique about Toyota was the management system. And, I was incredibly motivated by the Toyota Way and various books, and then going to see Toyota plants. And you just see how they work and how they're engineered and their management system is architected to support that frontline improvement. So the first thing we did was start to build that basis of, a lean management system. Because I tell my leaders, there are at least 3 things you have to do to be a leader. One is you have to set and hold standards. If you're not setting and holding standards, you're not being a leader. You're just showing up and going for a ride. You have to have an accountability system. So how do you hold people accountable? So if you have a standard and you're not meeting that standard, how do you hold them accountable? But not penalize them necessarily, but drive improvement around performance to that standard. And then the third thing is you have to make meaning. I mean, especially these days, but it was true in the 60s, it's been true since I've been in this business. People are inundated with information, and a lot of it's noise and a lot of it's temporally important, but over a long view aren't. How do you make meaning for people to say, this is what's important? And I think to be able to take advantage of this platform that we have in healthcare, which is, again, there's a selection bias. People come to this for all the right reasons, to care for people. That's your common ground that you get to stand on. So how do you make meaning, use that common ground, but use that as a motivator to say, and we have to change to be able to do this thing that we're all here to do. So that was a lot of those early years. That, and then trying to address the U of M relationship, which I didn't fully appreciate when I walked in the door, how challenging that had been since Fairview bought the academic hospital out of distress in '97. That it had not been a good relationship. And I was used to Stanford, which, I mean, it's not a perfect relationship between the healthcare organization, Stanford Healthcare, and the School of Medicine, but it was good and got better over time. That was not what we had in Minnesota. So being able to then attend to kind of the academic side of this and how do we build a different relationship, which feels like we've been in a continual process for 10 years now. Hopefully we're getting to the other side of it.
Yeah. And maybe just for listeners who aren't as aware, obviously I've seen headlines, but I'm on the outside looking into. Could you kind of give me a breakdown of that whole kind of dynamic and kind of the current state of things today?
Sure. To the degree that I know it.
Sure. Fair enough.
So I don't know where to start the story. So my belief is there was always a bit of a resentment around that the university had to sell their hospital. And I think that colored a lot of things in a sense that they weren't, fully formed Big Ten university because they didn't own a hospital. The good news is in the relationship with Fairview, they got scale, and Fairview added an existing hospital that it had on the campus on the west bank of the university, West Bank of the Mississippi. And then they built a children's hospital on that same site. And so now you have 3 facilities. They added an ambulatory surgery center. Now you have 4 facilities. And so there was an ability to expand the offering, but there was still this kind of lingering resentment. So when we went into the proposed Stanford merger, a lot of that came to a head. And there was a lot of rhetoric about, we can't turn over an asset like the university to a foreign entity from South Dakota. I always laugh when I go over the state line between Minnesota and South Dakota. You can't see a lot of difference, but evidently there is one. And so a lot of that came to a head in that. We ended up not doing that merger, which I will go to my grave saying strategically that was the most obvious thing to do in the world. But again, it goes to mergers are hard to do in the best of circumstances. And a lot of things have to line up to get them done. And the public sentiment and the university didn't line up in a way that we could get it done. But
that's interesting. Sorry, I didn't mean to cut you off. I apologize. But I'm just curious, when you say like strategically it made all the sense in the world, what were the kind of the components of that you identified as attractive?
Well, part of it was size. So we would have been the 10th biggest care delivery system in the country. So scale does matter in terms of your supporting infrastructure. The fact that they were contiguous. So, we always, people think of Stanford as a Dakotas, but they have Western Minnesota hospitals as well. But we were contiguous in terms of our geography with no overlap. So it was like, how often does that happen?
Yeah, fascinating.
Stanford sent a lot of their tertiary quaternary cases out, but not to us, to the University of Minnesota, but to Mayo. And so there was also a built-in opportunity. And, wearing my quasi-University of Minnesota hat, I was thinking, okay, well, look, this would place the U of M in the middle of the 10th biggest care delivery system in the region, the dominant player, even with Mayo. We've been bigger than Mayo. In many ways, would have been a more dominant system. And they would have been in the middle of it. And I didn't think at the time when Bill and I were originally talking about this, that we were going to end there, that we'd do this merger and then we'd move on and consolidate others, that this had the opportunity to be a very large system. Oh, and by the way, they have a benefactor who's going to relieve them $7 to $8 billion or some number like that at his passing. The other standing joke I have is you want to have a successful healthcare strategy, start with a billionaire. Doesn't matter if it's, Bloomberg or it's Javits or it's Li Ka-shing at Stanford. It's really very helpful to have a billionaire backing you.
Yeah, is that recorded on the balance sheet? Future promise of.
It should be.
That's interesting. That's very interesting.
So there were a lot of good things about it, and to have access to that kind of unfettered capital, to be able to both, whether it's the university or whether it's the system as a whole, and what you can do with that. My very rational strategic point of view didn't win out at the end of the day. But as I said, it did kick up a lot of feelings. The university came out and said, well, we want to build our own hospital, which was very unrealistic. The days of a standalone ivory tower hospital are pretty much gone in academia. And so we said, well, fine, if you want to buy the academic assets, we can do that. We spent a year, had a letter of intent, but never got across the finish line or anywhere close to it. Then it got pivoted into this current process with the AG. And I think the experience was such that it wasn't clear what the university wanted. And so it was hard for people to get a hold of, here's what we're trying to decide whether we're going to go this direction or this direction. It was hard for the university to describe what the other direction was. And then they proposed a merger basically that said, James, you should put your assets all into this new company, and Essentia will put their assets in, and we'll replace you and your management team and your board. And we're in wonderment that we didn't jump on that opportunity.
Now wonder why.
Yeah. So we're in a process now where we're very close to having a definitive agreement with the faculty practice group, which in my mind is the most important thing. That's where the value is created. It's with the faculty, and it supports the med school. We could be on our way to something with an agreement with the university, but it's fairly limited. I mean, it's things about brand and supportive research and teaching that we're, I think, fairly close on. So we may get over the finish line on this, but the most important thing is the relationship with the faculty. And so we have a binding term sheet for a 10-year agreement that supports the faculty, stabilizes them, supports the med school. So I believe it's going to give us a pathway to a much better future here.
Yeah, that's fascinating. And obviously faculty makes the most sense strategically. I'm curious, when you think about, contextualize this kind of relationship within the, overall turnaround story for Fairview, how much of what you did strategically within this relationship was attributable to kind of, financial and operational improvements versus other initiatives you had at Fairview?
Almost entirely on kind of operational improvements. Now, the one exception to that would be specialty pharmacy. So we did a number of things to expand our specialty pharmacy offering, including now having spun it out and offering it to other like organizations, because we're really good at it.
That's right.
And we're
So
seeing good uptake in that.
Just as background, and remind me again, it's Fairview Pharmacy Solutions, correct?
Correct.
And
yes.
You spun that out recently, and there's a history of specialty pharmacy kind of operations. Can you kind of give me the backstory behind how that came to be?
Yeah. So we have a terrific leader in Bob Beecher, who really started the program back in the 90s and has built continuously, gradually, and built this program out. Fully featured capabilities. We have a friendly pharmacy benefit management company, right? So it's really a full featured offering. And so that's what we now are. And 340B is complex, to say the least. And the compliance and revenue cycle side of this are equally complex. And that's what we're really providing to other organizations, is the ability for us either to outsource or for us to help build their capabilities. But, our desire obviously is to have an enduring, recurring set of revenues that are beneficial to both organizations. And we're seeing reasonably good uptake on that as more and more pressure is being placed on care delivery organizations and the need to look for other sources of diversified revenue are increasing. This is a great offering for us.
Yeah, and that's I feel like this conversation is kind of good timing, given the fact that it seems like there's so much going on with specialty drugs and utilization, and you got like the drug distributors, kind of vertical integration and those sorts of things. How would you kind of define the current state of both 340B, and then if you were to talk to other hospital and health system leaders trying to stand up specialty pharmacy or supercharge their operation or those sorts of things, what are the kind of things that you would look out for?
Well, I think the biggest thing is you shouldn't let 340B drive the program. We're intentional about talking about specialty management and specialty pharmacy management, because that's really what it's about. It's about the patients and being able to manage patients effectively. And one of the data points that I so appreciate, both Bob Beecher and John Pastor, are two leaders of our pharmacy organization. They can show you that if patients, complex specialty patients, managed under our guidance, our PMPM, our per member per month spend, relative to a matched cohort, is significantly lower, right? So we do a better job of getting people on the right drugs, keeping them on the right drugs, managing those transitions than just hoping that good things happen. And so my advice is for organizations like ours they undoubtedly already have a 340B program. And there are a couple of big organizations, others who are out there helping organizations set up 340B programs. In fact, we helped one of them get started. Is they don't have the depth of understanding and of the complexity and of the clinical side. For them, it's much more of almost arbitrage of I can buy drugs on the discount and sell them higher. I don't know that that's a sustainable business model. At the end of the day, it's got to get connected back to care. And 340B is an important part of that, but it's only a part of it. But it's critical in that you've got to manage that program well. And it gets harder and harder given the pharma industry hates the program and are doing everything they can to either kill it in DC or just add friction to it to make it harder to obtain the drugs. So in that, and the other thing that I think is kind of step to the front in many ways is infusion therapies. It's become such a big part of care, and especially ambulatory-based, outpatient-based infusion. And that's the other thing we're really good at, helping organizations set up broad-based infusion programs.
Yeah, fascinating. And it feels like infusion is going to be such a hot topic point in 2026. Yes. Can you talk a little bit more about kind of standing up that service line and what that entails?
Well, I'm probably not the right guy. I don't have as deep of experience, but it is about, so much is in healthcare is driven by the economics, and as the economics changed around both for oncology drugs and where med-oncs want to be able to infuse their patients, but just all the clinical indications where infusion was appropriate, but then the economics was, we don't want to do this in a hospital setting. We want to do this in the outpatient setting, and we're going to create incentives, economics to do that. The volumes grew, and the necessity to have a pretty significant ambulatory capability was almost forced on us by the nature of the economic reimbursement. Has created a growth opportunity for a lot of organizations to be able to really build out infusion and to be able to take advantage of some of the opportunities given the demand for and the volumes of infusion, not just in oncology anymore, but across modalities.
And when I think about infusion, I like the whole kind of site neutral things that are happening, and then just the amount of interest with hospital and health systems, and then also the vertical integration with payers as well, right? Like I think it was Elevance that bought Paragon recently,
Yeah.
those sorts of things. Just feels like there's a lot happening in that space and in specialty drugs as a whole.
Yeah. Well, it's such a big driver of cost these days. I mean, it's the fastest growing driver of cost. It's not the biggest cost element, but it's the fastest growing element. And I mean, that gets people's attention.
Yeah, absolutely. Okay. So we've talked a little bit about the academic relationship. We've talked about specialty pharmacy and pharmacy and how you're spinning that out. Talk to me kind of about the other processes and nuts and bolts you kind of alluded to earlier. What were the other parts of, transformational kind of turnaround? It sounds like you're a very process oriented guy and you care a lot about, the details and, like you said, leadership style with accountability and a purpose and those sorts of things. So can you break down like what were some of the maybe larger components of how, the turnaround happened over time?
Yeah. I mean, the three critical kind of categories. One is the labor side, right? We're a labor and supplies business. That's where our costs are. And coming out of COVID and kind of hyperinflationary period that followed, we had lost control of our labor expense. And so job number one was really getting that under control so that we knew where we were using registry personnel, why we were using them, and then to be efficient and effective about recruiting to replace so that we could have our people. It's also about overtime and how you're using overtime and how you're putting together your basic kind of circles of defense for, I always laugh when people act like it's a surprise when somebody called in sick and they're scrambling. It's like, look, people call in sick all the time. We should have a plan, right? We should know what our circles of defense are. So, what are we doing with our own float pool? How are we using cross training? How are we using, the various ways that we can expand and contract our labor force on the margins? So we did a much better job of that. The other things, it's the labor side, it's the supply side, but it's also the throughput. And for us, throughput is huge. We're not in a position where we have excess beds, right? So that's a good thing. We're not sitting on a bunch of fallow beds and, fallow capacity. The challenge is we've got more demand than we have capacity. And so how do we make sure the throughput is such that we don't have patients sitting in beds, in hospital beds, who don't need to be there? And so we spent a lot of time on that throughput. And it's true in the ambulatory side too, is you don't get access unless you got throughput, right? If you don't have output, you don't get input. And so you've got to have good throughput, whether it's in a clinic or in any operational setting, but especially in a hospital, because those are such expensive assets, right? An OR, I always used to laugh, right? The OR at Stanford might be the most expensive real estate in the earth, right? I can't
square
imagine.
foot.
Yeah, per square foot. I mean, I don't know what would be more expensive, maybe a nuclear reactor or something. But these are very expensive assets. And you want to be able to use them, both in terms of the fullness of the day. So you don't want to be shutting an OR down at 3:00 in the afternoon, but you also want to make sure that you're getting everything lined up so you can use those assets efficiently. And, the choreography of a hospital, right, is these things are not independent, right? So your OR throughput is completely dependent on the rest of the house. Your ED's throughput is completely dependent on what's going on in the floors and the rest of the house. And that's all dependent on, can you get people discharged in a timely way? And so we really looked end to end and raised every possible rock and said, okay, what are the big things that we can do that really make a difference? And so we've seen significant gains in our average length of stay, but midnight sends is a crappy measure for throughput. And so we've done a bunch of things around time of day and how many discharges are we seeing by 11:00 and trying to smooth that process. We've done a lot of things on the supply side. So how do we, minimize the number of SKUs? How do we maximize our purchasing power? How do we minimize the shrinkage we have in inventory? And all those things that go to your cost of goods and the supplies that go to that. So it was literally turning every rock over the course of a year and a half. But nothing like a near-death experience gets your attention. And when we lost $350 million that year, that was like, okay, we got to everybody on board. We got to turn this thing around. And it's the thing about healthcare that I've always appreciated is we're really good in crisis. It's kind of what we're engineered for. You walk into any healthcare organization and say, when were you guys at your very best? And they'll talk about some kind of emergency, a strike, downed plane, an earthquake, something that required everybody to set down their politics and really focus on getting the work done and focus on the patients. That's what people tend to cite. And we're very good at that. And so this economics, the kind of fiscal crisis really created that focus, but it also created a sense of belief that we can do this. And so really got our swagger back. We, demonstrated the results. And what I'm most proud of is it's not just the economic turnaround, because you're taking a process view. I mean, the performance dimensions of that process are quality, safety, service, engagement, how much you're supporting research and education, and the amount of resources you're consuming. And so being able to then get the cost improvements, but also see the highest quality output that we've had ever in the organization, highest customer service, which we surpassed again this last year ever in the organization, engagement scores in the top quartile. That all goes to the methodology and the approach. And I trace a lot of it back to the fact that we started with kind of lean management methodology, 10 years ago, gave us a platform to really build off of as we're in 2022-3 going through this economic turnaround.
Yeah, that's fascinating. And to your point about kind of like throughput management, you guys own post-acute assets, do you not?
We do. We have a very large subsidiary called Ebenezer that has a set of owned post-acute assets and then managed post-acute assets.
So how big of a role was owning that asset? Was that helpful in kind of that whole kind of spectrum, or not as much?
It was very helpful in that we could coordinate. We didn't have to. I mean, the big thing for a lot of skilled nursing facilities is you want the easiest patient who you can keep for 21 days, right? Because that's your reimbursement. And again, reimbursement and the economics drive so much of our behaviors. So because it was a subsidiary, we could have a different kind of conversation about it's okay if they lose money on this patient, if it's a more complex patient. We're okay with that. You don't have to maximize, but we're saving the hospital bed, which has much more value than the skilled nursing bed. It also allowed us to be able to flex resources so that we could bring the kind of clinical capability that you need to be able to handle more complex patients in that environment. Unfortunately, in Minnesota, skilled nursing facilities are the reimbursement mechanisms are not inducive to having more of them. So we have a lot of assisted living. So we didn't have enough skilled nursing facilities ourselves. So we had to create other relationships to also help that flow, as well as working with the state. We had a lot of folks who basically were in a hospital bed because nobody else wanted them. Their group home or whomever else, they were too hard, their behavioral issues, et cetera. And so they just drop them off in the driveway of the ED and walk away from them. And so we had to do a lot of work with the state to be able to provide safe, effective avenues for those patients so that we weren't ended up being an institution where we're the most expensive hotel in town. That made no sense. So it was just a lot of those things that went to either throughput or kind of other aspects of operations.
And maybe like just backing up slightly, can you just maybe quickly break down the framework of kind of lean management and how that relates to healthcare and in Fairview?
Sure. Yeah. I really think of it as three subsystems. So one is strategic deployment or Hoshinkanri. So, the question is, how do you create goals at the top of the organization, executive side of the organization that translate all the way down so that people have line of sight to this is what I'm doing to contribute to the success of the organization. So quick aside, right? So I first learned this when I was in Seattle. I happened to be in a primary care clinic, and this is where we first started implementing lean. And I was talking to a medical assistant, and they had their visual system up and their charts and said, okay, so our goal is X in quality. What are you doing to contribute to that? And without missing a beat, she looked at me and goes, I'm calling 5 patients every day. Interesting. Why are you calling 5 patients? Because the math would say, if I call 5 patients, we're going to get 2 in clinic. And if I get 2 in clinic every day, our number needed to achieve target is going to be 0 by this point in time. Now, well, that's a level of sophisticated thinking that most of the time, you're not going to encounter randomly talking to a medical assistant in a clinic.
Yeah.
So they can have a complete line of sight, right? And that happened through a series of conversations up and down the organization, so-called catchball, right? So that's one. Value stream analysis. So, we tend to think of organizations in terms of our functions, but that's not how patients experience. They experience the value stream. I come in here, I have a series of events, and I leave here. Might be a cardiology issue, might be something else, but it rarely is at a single point. And it's that managing that continuum. So a lot on value stream analysis. And then the idea of quality and daily work life. So how do you create the kind of environment where everybody has a sense of the quality? So your visual systems and your huddles. So the first thing we implemented was a set of huddles that started at 7:00 in the morning. Every day culminated at 9:45 with my huddle, with my direct reports and others around, are we ready to run today? Or do we have any issues that are going to keep us? It's less about the huddle itself and the crosstalk that happens, and people solving problems in near real time or getting them to the right level of the organization to get solved. And so those are the aspects that we train and teach to and try to create systems around, are those three subsystems. We're just, we're through the another year of strategic deployment. Every year it gets better. You start out, you really do suck at it. It's hard, but every year we get better and better and better at it. Value stream analysis kind of fundamentally changed the way that we think about how pieces of our organization relate to each other. But the most powerful is that quality and daily work life, and that people can see the results and can see the work and are engaged in there, and really driving their own improvement in so many ways.
Yeah, and it's kind of answering the question, you matter and here's why, and those sorts of things
That's
too,
right.
and feedback loops. Yeah, that's fascinating.
That's
I'll
exactly
have to do some more research on it.
Yeah.
Cool. Well, okay. So talked a lot about a lot of things today. Love to kind of wrap up the hospital and health system and healthcare side of things with maybe talking on innovation and AI and those sorts of things, because it wouldn't be a podcast without talking about those things, right? I'm curious, just like as you sit as the CEO of Fairview, what's your take on the state of AI today, and maybe like, could you walk me through maybe one deployment that's working really well for you guys, and maybe one deployment that wasn't so great?
Yeah. Well, first of all, if I back it all the way up, I'd say that healthcare and healthcare delivery have no choice. We're going to have to innovate our way out of this, right? And there's going to be a strong technology component to this to enable that kind of fundamental transformation. I think AI is going to be a big part of that, but not the only part. The place where we usually make the mistake is we fall in love with the technology and forget the people and the process part. So those three have to be in concert, right? The people, the process, and the technology have to work together. So we're not just paving the cow paths and basically repeating the mistake that we made as a country around EMRs, which is, we slapped in a bunch of EMRs, but we didn't fundamentally change the way care gets delivered. We created, paved the cow paths, as you were. And so, if I think about AI, just because of the immense potential of it, thinking about, so like we've implemented NABLA, passive dictation, right? So you put your phone down, physician comes in, starts talking to the patient normally, but NABLA is picking it up, and then doing the documentation for your review in the EMR. It's very seamless. It's a game changer for physicians. And the adoption we've had across our, call it 2,500 employed physicians has been significant, and generally deep love for it. We did a chest X-ray algorithm. This, you could argue whether it's AI or not. It's not large language model driven, but during COVID, that was a game changer that allowed us to see patients in the ED and have a high predictive validity around, can we send these people home safely or not? Well, at the time, that was huge because everybody was presenting in the ED with these symptoms of this novel virus that we didn't know exactly how it was going to play out. We've had others where it hasn't worked as well, mostly because we didn't pay attention to process and people, where we just throw the technology down and then wonder why nothing happens. why it doesn't, get picked up and leveraged in the way that was anticipated. But I think we've learned our lessons well on that and do that fairly rarely now. But I think that the real potential with things like large language models, specialized language models, general kind of AI approaches is going to be our clinical models, and that's going to be the hardest one. Right? We'll do a lot of things on the administrative side. We're already doing a lot of those things, call centers, et cetera, automating tasks that really are fairly easy to automate, take the burden off people. But why wouldn't this impact our clinical models? And I always go back to the idea that the expansion of clinical knowledge is happening so quickly, right? There was a study done a number of years ago that I read that was, if you were a brilliant medical student in 1950, at the rate that the scientific body of knowledge is expanding, you would not expect it to double until 2000, 50 years later. You go to 2020 and say, okay, you're a brilliant medical student, you've learned the entire body of clinical knowledge. How long is it going to take to double? It's like 7 months. And the way that we've tried to manage this in healthcare is hyper-specialization, right? So you get narrow and narrow specialties so you can manage the breadth of content. That's simply not going to be sustainable. It's no physician can keep up the pace of innovation and scientific advancement, but AI can. So now, what does that mean in terms of who is the clinician and where does that content knowledge coming from? And I'm not saying you can replace the clinical, because there's a very much a relationship and a people side of this, but you can certainly augment it, but it's going to change the way that we think about our clinical models. Why wouldn't an APP at, a third of the cost be a better first-line cardiologist who has the complete body of cardiology's evidence-based graded knowledge on her shoulder, as opposed to a cardiologist who, is doing all the right work, reading the journals, going to his book clubs, but it's hard to keep pace and gets 3 times as much on a salary basis. So I think that it's inevitably going to happen. The economics are going to dictate it. The question for us is how much are we going to lean into this and really be an active agent versus we're going to be a recipient and be a victim of the change. And, obviously my advocacy is I want us to lean into this and really be at the forefront of driving the change.
Yeah. And I'm curious, as you guys look to drive that change and the right change and make sure that the processes and the people don't break down, like what do you foresee as kind of barriers within those components to that end?
Well, it's going to be people, Blake. I mean, the difficulty is always in the change management side, right? And, can you create the WIFM for somebody? And it's hard, especially here, because people are worried about being replaced by the technology. That's where it's good that we've got, plenty of demand, and we're not, having to worry about not being able to fill the clinics, not being able to fill the hospitals, et cetera. So the opportunity to really create the what's in it for me. We did this in Palo Alto a number of years ago when we changed the primary care clinical model. The problem was people were having to go back to Epic at night after dinner with the family in their pajama time to close their charts, to empty their in-basket. And Gary Kaplan in Seattle had demonstrated that you can engineer through lean methodology a clinic that you're done at the end of your last appointment, 30 minutes after, you're done. Charts closed, documentation done, in-basket clear. Well, that's the WIFM, right? And so to be able to sell that kind of change, and it required a lot of change, but for the primary care docs, that's what was in it for them. They could walk away at the end of the day and really be pretty much done. And that allowed them to engage in the changes that had to be made for the promise of that outcome. So we got to find the WIFM for people. And that's why NABLA has worked. I mean, it's changed the way that people practice and unburdened them from being tied to Epic.
Yeah, absolutely. Big fans of NABLA over here as well. So great to hear they're doing great work at Fairview. James, got one more question for you. It's a non-healthcare one I like to end the podcast with. What is a recent non-healthcare piece of content or media that you read or consumed recently that just left a lasting impression on you?
Oof. It's not a recent one, but the one that helped me better understand our industry and continues to influence my thinking a lot was that Economist article from October of, must have been 2023 or 4 now, 3 probably, around, our $4.5 trillion industry in the US called healthcare. Where is the money spent? And the fact that, we always talk about half the money is being spent in hospitals. That is correct. But the other half is spent on the middlemen, right? It's the PBMs, the health plans, the distribution companies, the med tech companies, the eye tech companies. It's all the others who don't directly create value. And a lot of them depend on the other half of hospitals and healthcare systems for their revenues. That kind of picture of the overall economics has been incredibly impactful in terms of my thinking about what it's going to take to be successful in healthcare, and what kind of partnerships we're going to have to create, and maybe getting a little out of the box in terms of who we think are our partners and, partnering on what. That's the one that jumps to mind.
Awesome. Well, that's very interesting. I'll have to look up that article. Maybe we can even post it in the show notes or something. But
you should.
We'll definitely read it, and looking forward to seeing future partnerships, future tech, future transformation from Fairview and you guys. James, good luck this year. I'm sure we'll be in touch. But thanks so much for the time today, and it was a great conversation. Learned a lot.
Blake, I always appreciate it.